Hello, a very warm welcome from Vienna to our winter hearing meeting. It's about our 11th or our 12th meeting already. And for this time, we have a very special topic. It's about cochlear implantation in the elderly. We have a wonderful lineup of experts in this particular topic. And nevertheless, I want to start now about the hearing. The hearing group was founded in the years 2007 and then finally in 2008 as an expert level for audiologists, cochlear implant researchers, and all the people in the field to be a center of excellence. And we are a worldwide group of people. It is a global network of 31 centers so far all over the world, and we live for audiology and implantation. So every year we do quite a number of papers setting the standards, and now this is already the third year we have a quarterly meeting, a quarterly broadcast about the recent topics concerning cochlear implantation. This time cochlear implantation in elderly people. Our group is working strongly together to be educative and also innovative and comprehensive. Please be aware what is broadcasted now is all recorded. You will find it in a few days also on YouTube. Please quit all your programs to have the best connection. It's also interactive. Please mute your microphone. And if there is any problem or any question, please ask a question. We will have later on a discussion, and you're also very welcome to bring your input in. Please name yourself, name organization and country, and use the raise hand button. Yeah, so the meeting is recorded, and I want to introduce these wonderful experts. First, Professor Javier Gavilan from the University La Paz in Madrid. He will also moderate the meeting. It's a very special honor for me to see Professor Griet Mertens from the University of Antwerp. I know her since a very long time, and she is really an outstanding expert in audiology and especially in this field. Then also a person with a long outstanding experience, Professor Chris Rain from Bradford, UK, from the Cochlear Implant Center. Then from the other part of the world, down under, Professor Daisy Tavora from Perth, Fiona Stanley Hospital. She also works since over a decade in the field. She did a lot of scientific papers. And last but not least, I'm very happy about him, Professor Domenico Cuda from Piacenza. We know him all. He wrote at the moment the White Book of Cochlear Implantation for the Italian Society of Otorhinolaryngology. He's also the current president of the Italian Society of Otorhinolaryngology. And it is a very big honor for me to have him here as a new guest, a new fellow to join us. Domenico, all the best. And now I need to tell you that also this broadcast is certified. It's certified from the University of Würzburg, so you will have CME credits. So we have a special standard provider, so you get CME credits for this broadcast. And now let's stop with the introduction. Let's go to this very special and important topic nowadays, cochlear implant to the elderly. And we now move on to Madrid to Professor Gavilan.
Hi, Baumi. Hello, everyone. And thanks a lot for being on the other side of the screen. Welcome, as Baumi mentioned, to the winter edition of the Hearing Roundtable program. When we started this program during the pandemic, online meetings were the only available option we had. Nowadays, with a much more normal situation, the hearing group has decided to continue with our quarterly online roundtable program with the idea of providing an additional educational tool, especially for young doctors. It's much easier for you to attend an online meeting, of course. Today, as has been mentioned, we will try to explore the frontiers of cochlear implantation in elderly patients. And for me, this is a especially appealing topic, not only because we will all hopefully become elderly patients in the future, near future for people like me, but also because life expectancy is increasing in most countries, and the incidence of cochlear implants and the indications of cochlear implants are expanding at a similar speed. Over the next 90 minutes, we will share with our panelists the experience and the indications and the results and risks associated with cochlear implants in the elderly. At Hearing, we would like to make these roundtables as interactive as possible. And during the discussion that follows every presentation, you will be able to ask the speakers directly by raising your hand on the chat or using the microphone available in your Zoom connection. And to start with this interaction and demonstrate that we really want to participate, that we really want you to be able to interact with the speakers, I would love to ask you to switch on the camera of your cell phone, get your cell phone, switch on the camera of your cell phone, and scan the QR code that we had on the previous slide, or you may, this QR code, or you may go to www.menti.com and introduce this code, these numbers, 5495-6636. I think it's easier to scan the QR code. You can scan the QR code and you will enter, you will access the Mentimeter, where we are going to keep a communication with you on the web. This Mentimeter will have at least two questions. The first question is right now, and it's what are the benefits of implanting older adults? And you can answer as many items as you want. You don't have to answer just one item. So what are the benefits of implanting older adults? Lower levels of anxiety and depression, decrease of negative and social inhibition, improved quality of life, increased self-reliance, cognition, improved hearing capabilities, improved spatial orientation, or other that you may think are not considering these 2, 4, 6, 7 options, and you consider them to be important. So please go ahead, continue answering, and we will have one more minute for you to complete the registration at menti.com, www.menti.com, and use this code. And you can also scan this QR code, and please give us your feedback. What do you consider that are the main risks of the main benefits of implanting older adults? As you see here, improved quality of life looks to be a bit higher than the others. Improved hearing capabilities, of course, this is obvious. And then we have cognition, decrease of negative and social inhibition, lower levels of anxiety and depression. So more or less, the 7 items we recorded here are more or less similarly distributed. Okay, please keep your phones close by, because we will have more questions coming after the presentations. And now let's start our journey. We are going to, during this afternoon, during the next 90 minutes, we're going to travel all over the world without jet lag. And the first stop will be in Perth, in Australia. We are in Perth to meet Professor Daisy Tabora Vieira. Daisy is the head of the audiology department at the Fiona Stanley Hospital and adjunct associate professor at the Medical School of the University of Western Australia. Her research has been focused on treating single-sided deafness and associated tinnitus with cochlear implants. The hearing group is very lucky to have Daisy among our remarkable experts. And Daisy today is going to deal with the topic saying, is advanced age a predictor of cochlear implant outcomes? Daisy, it's all yours.
Thank you, Javier, for the introduction, and thank you, Hearing, for the opportunity to be here talking about this topic. What I think that is definitely very important for all of us. Well, I think that there are two things that we can say for sure, right? Two factors. One, as you said, Javier, already, is that we are getting older. All of us are getting older, and globally, the population is getting older. So let me just make sure this is working. That's it. Actually, according to the World Health Organization, 1 in 6 adults actually will be 60 plus by the end of this decade, right? By 2030, we are going to have 1 in 6 will be 60 years old or older. And another thing that we know, I think that the second thing that we know is that older we are, more chance of having hearing loss we have. And again, if we look at the World Health Organization data, I'm just going to go back here, the prevalence of hearing loss increase with age. If we look at the 60 to 64, we have around 13%. If we add 10 years in age, we double the prevalence. And again, if you go another 10 years older, you are talking about 45% prevalence. And the 85 plus, you can have even a prevalence between 50 to 60% of these people. And we are talking about moderately severe to profound or no hearing at all. So we are talking about the prevalence of hearing loss of people who potentially could be a CI candidate. What is interesting is that less than 10% of these people actually receive a CI. So I think that this is a topic for another meeting altogether. But let's park this, and I will share with you what we did. If we really want to highlight hearing as an integrated care for older people, as proposed by WHO, I think that we need to understand this population more. So we're pretty lucky in our center that we have a wide range of age. We have from kids to 95 plus also patients. So what we did was we wanted to see how this older population compared to the younger ones. So we took a cohort of 423 adults, and we separated them into 3 cohorts, smaller cohorts. So those who were younger than 60, those who were 60 to 75, and those who were older than 75. Just to highlight that in terms of percentage, the younger than 60 were 37%, and older than 60 was 63% of the total cohort. And we wanted to compare their outcome. So the first thing was the speech intelligibility in quiet, and nothing new there. I think that is very consistent with the literature. We looked at only within the first 12 months. So we looked at the pre-op 3, 6, and 12 months, and nothing new, as I said, very consistent with the literature. There is a significant improvement for all 3 groups. What was very interesting is the fact that there is no difference between the 3 groups. This was also for the speech noise. There was no difference between them. In terms of quality of life, we looked at the SSQ. We used the speech spatial quality of hearing, the 12 questions version. And again, all 3 groups improved over time and with no significance between the 3 groups. Tinnitus, of course, I think that we all agree that tinnitus is a major issue when you are talking about deafness, although it's not everyone, but it is a major issue. And when I look at tinnitus, again, all three groups improved with no significant difference between them. I think that it's really interesting to see these results, and it's very encouraging to know that age per se, we are going to be talking about other factors later on, but age per se is definitely not a contraindication and should not stop us offering this possibility. And that's my bit. Thank you.
Thank you very much, Daisy. Let's move to the discussion. And I just want to let you know that for the discussion, all the panelists are admitted that they can ask questions and answer the questions. And we also will take the questions from the audience. And we have first question from Professor Hagen, which is on the other side of the screen.
Okay, can you hear me?
Yes, we do. Hi.
Hi, I'm just arrived in Hamburg on the last minute, but my question to Daisy, how do you proceed in persons with a slight dementia? Are they an indication if they are not able to handle their implant completely by themselves, but they have a chance to improve to stop at least for a little while the progress of dementia if they can hear? What's your opinion?
Yeah, that is a very good point, Professor Hagen. Actually, in our center, dementia it makes them a priority, to give you an idea. So, for example, all our implants are discussed in our MDT, and if they have early onset dementia, or if they are already diagnosed with dementia, they are actually given priority to have the implant before other ones. So yeah, that's very good point.
Good. Thank you very much. I have a question from the audience, and I want an answer from each one of you. And I want just a number or a word. The question is, which is the maximum age for implantation? If there is no, you say no limit. If there is an age, can you tell me? Daisy, we start with you.
No limit.
Great.
As long as there is no medical contraindication, no limit.
Great. Chris.
Again,
no age limit.
No age limit. We've done a 93-year-old. It's all part of the medical assessment and their wishes at the end of the day. We'll discuss this later as well.
Good. Great.
Also no age limits in Antwerp.
Domenico, in Italy?
No age limits, just a question of life expectancy, of course.
Good. So, as you can see, there is no age limit for cochlear implantation as long as the patient is fit for the procedure. Now, from your presentation, Daisy, it looks like every old people is the same. It doesn't matter if the old is like me, 60 something, or if the old is 95. This is exactly what happens in all your practices?
So let us say, Javier, yes and no. For us, doesn't really matter which age, if they are fit for surgery, as I said, and if they, we try to work with them differently. I think that the needs are different. The way to work with them are different, and the outcome can be different. But what we reach at the end is that there is no difference in terms of outcome from what they are expecting and then what they achieve. There is no difference in age. The age is not going to stop that. But you have to take into account that you need to provide different means. And
do you all agree? It's the same as 65. I mean, for a cochlear implant, Domenico, it's the same 65-year-old guy than a 95-year-old woman?
In our experience, no. From the point of view of speech perception, especially noise, they have very different results. But if we consider in terms of quality of life, the benefits are significant also in the older people. But when we concentrate just on some audiometric test, we can observe a decline in speech perception.
Good. They are saying here that in the UK, they implanted a 103-year-old this year. So we look like no age limits. And well, if there is no limit, I mean, if the age is not a limit, it's not a predictor of good results. Can you tell me what are the predictive factors for a successful treatment in the older adult? Great.
Well, from my point of view, it's
go ahead, Chris.
Oh, sorry, so great. So I was going to say I'm talking about this later on regarding the selection of patients. But obviously,
Okay,
the
so
outcome
Great. Can you tell us your opinion?
Yeah, I think a lot of variables are of importance in these older adults, but maybe the most important one is the rehabilitation afterwards. If the patient is really motivated to do the rehab afterwards, then I think age is really not a variable or counting for it.
Okay, I have a question from the audience for Daisy. I don't know if I understand it well, but the question says, which kind of noise did you use? And they found for fluctuating noise, worse performance in the 80+ aging group.
We used, we did not use, how do I say that? We used the BKBs in noise, which means that you have the speech remains the same and the noise goes up and down. So, and I agree with Professor Kuda, they don't, although they are more difficult they have on these tests, although there was no significant difference between the groups, but they do perform slightly worse on the test per se. Yeah, is that the question?
Yeah, I think so. I think so. One more question, and this is I think this is also coming from the audience, and I think it's important. You said all ages are the same. So what about the central auditory changes and dysfunctions that happens with age? They do not impact on the outcomes of cochlear implants? Who wants to answer? Daisy.
Yes, absolutely. Absolutely. One thing that we have been observing is that, remember that this cohort we looked at the first 12 months, right? So one thing that we observe is that older they are, if you look at patients who were implanted 10, 15 years ago, and they are in their 90 now, so they are performing much worse than what they used to do 10 years ago with the implant, even with the implant. And I think that this is probably linked to the ability to process the sound, right? But because we are talking about the first 12 months and we are going from pre-op to 12 months, probably we don't see that difference. But again, as you said, once they become older after the implantation, that's one more reason, right? I think that if we implant them much older, the benefit will be much smaller than if we implant them earlier.
Good. And concerning quality of life, I mean, we were talking, Daisy, you and me this morning about quality of life. And you know, quality of life is basically something about expectations. Your life is good as long as it matches what you want. If not, it's not good no matter what you have.
That's
right.
right.
Quality of life is the same for a 65-year-old person today than for a 95-year-old person. I mean, their expectations are so good that they match the aging process. What do you think?
Yeah, no, it is, if it is still me, that is a subject that fascinates me, Javier, you know that. And the short answer is no, it's very different. As you said the answer already, the expectations are very different. And what was very interesting in our study that I did not mention, because of course the presentation has to be short, is that when we looked at the quality of life, just looking at the SSQ, what we found was the younger population, they rated their quality of life 3 months after surgery, much worse than the elderly. And I think that is exactly because of the expectation. If you are younger, you are expecting much more, much quicker. If you are older, probably you have your expectation is much lower and you are more patient, I guess. They did much at 12 months, but at 3 months, the expectation from the younger population was much higher in terms of quality of life was poor. So our interpretation is that probably they were expecting more. But no, the quality of life for somebody at 60 and not the 90 is very different. Very different.
Of course. Okay, good. One more question, and I think this is going to be the last before next presentation. And I want you to give me also a short answer, all of you. The question is, what is the maximum duration for doing a CI in a patient who stopped using hearing aid? So someone stopped the use of hearing aid. Until when are you going to be able to have an implant and have good results? Read.
I'm not sure, and I don't have any evidence to give an answer on that. The shorter, the better, but yeah, I don't dare to give just one answer.
Chris, do you have same idea, or you have a given time?
Only in patient selection is that if somebody's not used a hearing aid, I mean, most of the patients that come are using a hearing aids or bilateral aids, but if you have a unilateral hearing aid user, we'd be very hesitant to implant the non-stimulated ear, say, if it hasn't had a hearing aid, say, for about 5 years, it would be part of our concern factor when we do the adult implant profile. So non-hearing aid use is a problem.
So we have the earlier, the best. We have about 5 years. Domenico.
Yes, I think that is reasonable, the consideration of Chris, but I have to say also that we lack of robust evidence on this. And sometimes we have attempted to overcome some reasonable limit, and we had sometimes the success, other time no. So I think that probably we need more and more evidence on this aspect. But anyway, it's reasonable, the consideration of Chris.
And for you, Daisy?
Javier, I don't have a scientific data for this, so I want to make this clear. Not a scientific, it's more a clinical experience. We have in our cohort, we have patients who have been were deaf without hearing aid for 47 years. I think that is the longest. And we did have a look at this at one stage, non-published data, but I think that what is more important than deafness duration is the onset. If you are talking about a 60 years old with a 45 deafness duration, means that he heard for 15 years. That is one cohort. If you have 8 years old with a 45 years duration of deafness, you are talking about what, 35 years of hearing, then the outcome is different. But again, I think that is this is a clinical experience, not a research data that we're presenting. But I think that's more important than the deafness duration per se is the onset.
Okay, we will go back to this in the next discussion. Now we are going to continue our trip, and let's go from Australia to Italy, to Piacenza. And we are in Italy to meet Dr. Domenico Cuda. Dr. Cuda is the head of otolaryngology at the Piacenza Hospital. He was the president of the Italian Hospital Otolaryngologist Association from 2014 to 2015. And now he is the current president of the Italian Society of Otolaryngology and Cervicofacial Surgery. Since his arrival in Piacenza in 2003, almost 20 years ago, his department has been a national and international point of excellence, especially in the field of hearing bionics. Today, Dr. Cuda is our guest, is a guest of the hearing group, and we are very pleased to have him among our speakers. And Dr. Kuda is going to deal with all you need to know about the benefits of CIs in older adults. Domenico?
Thank you, Javier. Thank you, and good day to everyone connected with us this day. So I thought to classify, to categorize, not to classify, the outcomes in 5 levels, but just for practical purpose, without any other target. The first level is the speech perception in quiet. As you can see, I show here some data of our experience. And we use, I have to say that we use in Italy the bisyllabic word because we don't have enough monosyllabic word like in other Latin countries. This is the material with a good compromise between low redundancy and meaning material. It's a meaning material, of course. So we can observe over time an increase of score in different, across all age. And in particular, I have to underline that the 80 years old people over 80, they score a little bit, in a significant way, a little bit lower than the younger senior. This is a first point. But the second level, in my opinion, is the speech perception noise. In the attempt to compare our data with other languages, we use the speech-to-noise ratio approach by the matrix sentence test, well-known test, so-called OLSA test also. And here we observe that over 80, the test is very difficult to perform, in part because of low score, speech perception score, in part because of it's a difficult task, probably for cognitive reasons. But if we consider people under 80, we can observe how very important difference exists between the class of 60, 69 and the class 70, 79. In this last case, we have a higher score, meanings, of course, work result, because to obtain 50% of perception is necessary a higher speech-to-noise ratio. Why this difference? This is very difficult it's a question of very complex variables. One of them probably is the cognitive decline associated with age. This is a typical experiment, a typical pupillometric experiment. And if we look here at the most prominent peak in pupil dilation, we can observe how under the same test of speech in noise, at the end of the listening phase and during the repetition phase, 81-year-old people had a wider pupil dilation respect to a 53 years old with the same audiological profile, CI plus hearing aid. Both are bimodal patients. This means probably greater cognitive load, and this is probably one of the variable influencing some decline in speech perception over time. But let me now introduce with the level 3 the PROMs. PROMs are the patient-reported outcome measurements. In this case, the level 3 is the level of symptom-based PROMs. One example cited before by Dicey is the speech and spatial and quality questionnaire. As you can observe in this sample, also in our experience, we have a very, very important increase, significant and clinically increase in this different domain. With the third level, we enter in the prompts dedicated to quality of life dimension. This is very important. It's important to consider that when we define the health-related quality of life, the target here is not just to consider hearing. Hearing is not central in the evaluation of health-related quality of life. We have to consider different aspects, in particular, the social and psychological well-being, and of course, also some physical limitation. The results is to obtain a profile in different subdomain in order to check for the effect of treatment and to compare also, possibly, hopefully, to compare with other pathologies, with other chronic conditions, in order to verify the effect of care. For example, with the SF36, a very popular questionnaire used all across the world, we can observe, for example, a significant increase in social functioning, despite the problem just observed in terms of speech perception in noise, for example. The last level is the same problem, the same analysis of different subdomain in the quality of life, but with another target. The target here is just to obtain a number. So this number is important to consider that is not just the combination, mathematical combination between different subdomains, but is derived from different weights given to the different domain, psychological, social, and physical. In the case of this instrument, the Health Utility Index 3 is taken in consideration also sensorial experience of the vision and of the hearing. So the final result is a number. So with this kind of instrument, it's important, the metric is important to have just one index. Also with this approach, we can observe here how respect to the baseline and across different ages, we can have a significant clinical meaningful gain of 0.13 in quality of life across all ages. This is clinical and statistically significant. This is very important from the point of view of health economics. So in conclusion, I think that we need to have a broad range of approach when we consider outcomes in our patients. And we have probably also the need to change attitude from the hearing, from speech and noise, from speech and quiet, and so on, toward also the reasoning typical of health economics.
Well, thank you very much, Domenico. And from your presentation, I found it's obvious that patients improve their quality of life, even elderly patients. That's the topic today. But I felt one of your first slides was a bit in disagreement with what we said before. It looked like patients up to 70 years of age did different to patients between 70 and more. Is this how can we combine this with what we said before about no age difference?
Oh, I think the worst results are observed in the over 80 patients. I think that the different factor can influence this, but the cognitive decline, a mild cognitive decline, probably make possible to perform bad at the test. But I have to say that the quality of life experience every day is very good in these patients. They use, if we check, for example, the data log of these patients, they use several hours a day. So there is a mismatch. Probably they take advantages from other aspect of hearing. Hearing is not just a score in a speech test in the hospital or in the clinic. Hearing is also to have benefit from listening to music, to perceive, to the safety of an alarm and so on.
Okay, Professor Hagen?
Yes. Can you hear me?
Sure.
Yeah.
My question is, did you observe any complications in very old people? Because we had one case when the patient was moved to the nursing home. Nobody took care for his implant, and the implant was sitting in place all over the time until he developed severe skin necrosis. So this is, in my opinion, a problem in the very old if they move from home to nursing homes, for example.
Yeah.
Is this a topic today or not, Javier?
Yes, of course.
Okay.
Domenico, did you see complications?
Yes. No, we don't observe more complication in the elderly respect to the other categories. I have to say that maybe it's a little bit more frequent, some vertigo, some dizziness after the operation. Sometimes we have some case with positional vertigo, treated by reposition maneuver, and sometimes some skin problem. But I think that this is a topic for Chris. Is correct, Chris? I think that sometimes the atrophy of skin create some annoyance in patient. We have to treat with some local therapy this kind of problem.
Chris?
Yes, it will be discussed in some slides, but I agree with Rudolf Hagen, that Professor Hagen, that skin in the aging skin is a problem that needs to be taken into account. And we have experienced issues over COVID because of failure to communicate and the fear of coming into hospital despite people's showing problems. But we can elaborate in more detail later.
Okay, good. I have a question from the audience asking you, all of you, do you include cognitive screening or testing in the pre-implant evaluation process? Great.
Yes, but we do it in all our patients, not only in the older adults, but really in all the adults scheduled for CI. First of all, they have to go to an assessment with our psychologist, and then a structured interview is performed to check whether they've got support from the family and the friends. Also an IQ test is performed, and yeah, just to see whether they will be capable to deal with the rehabilitation process. And in our older adults, but that's because it's in a research setting that we are testing them a little bit wider, and then we do the Arbenz age testing in all patients older than 55. But that's not just clinical routine, but more for research purposes.
Same in Australia?
Same in Australia.
And in England?
We do for everyone.
Also? And Italy? Domenico?
Yes, we give some screening with the mini mental state or MOCA, depend, in the old people, yeah.
Okay, now for the audience, back to the cell phone, back to the Mentimeter. We are going to ask you something related with the topic of the discussion right now. You go back to the scanning. If you lost the connection, you scan the QR code, or you go to www.menti.com and you have to enter the code 5495-6636. And when you are there, you will find another question. And we want this time just a word or a couple of words, as you see here, what are the risks of implanting older adults? You can put 1, 2, 3 words and just give us your feedback. Let us know what you think about the issues we were discussing right now. What are the real risks of implanting older adults? Problems in use, lack of rehabilitation, skin. Skin becomes a bit more frequent answer because it's a larger letters. Problems of using, surgical risk, dizziness, health, compliance, problems of using the equipment, general health condition. But again, the skin is considered to be a major problem. We may discuss a bit more about the skin when Professor Rain finishes his presentation, but right now we are just having an idea of the answer we have right now, 20-something, I think, answers, and we have more than 120 attendants, so we need more answers. We still have some time to get your answers. And compliance and dizziness, lack of rehabilitation. Well, the risk of lack of rehabilitation is something that we will also discuss during the next 2 presentations, and I think this is rehabilitation is a major issue with regards to the older adult population. But we have a more or less good image of your opinion, and I think we will also compliance and dizziness now becomes also in big letters. So we will discuss these ideas, skin, compliance, dizziness, and rehabilitation after the next presentation. And for the next presentation, we will continue our trip and we will move from Italy to the UK. We're now in Bradford to meet Professor Christopher Rain. Professor Rain was appointed consultant otorhinolaryngologist at Bradford Royal Infirmary in 1986. It's a while. He has special interest in pediatric and adult otology and is the clinical director for the supra-regional Yorkshire Auditory Implant Service. He is also a member of the European Board of Examiners in otorhinolaryngology and was awarded an MBE title in 2015 for his work for the NHS and the Ear Trust charity. Hearing is really honored to have him as one of our distinguished members. And as he's been mentioning this afternoon, he will deal with the difference between adults and older adults in surgical risks. Chris?
Yeah. Thanks very much for those very warm words, and it's a great honor to be on this panel. Really starting off with the assessment program. Back in the early 90s, Pat Shute developed what we call the Children's Hearing Implant Profile, and we've adapted that and I'm sure lots of other centers into a program, and we call this the APE. And the slide would be far too crazy if all the little anecdotal sentences and markers were put in to the no concern, mild and great concerns. These are sort of factors to look at. There are 12, 13 factors that we look at through the MDD process, obviously surgical, radiological, the speech language teachers of deaf for the children. So we will move to the other ones, is that some of these factors are, I call immobile, in the sense that they can't be changed. Audiological history, functional hearing, the duration of deafness, and obviously radiological factors all have to be taken into account no matter what age you're doing. But more importantly is looking at the medical side of things for the move that on. Yeah, for the elderly, I've taken out some of the factors that would probably be more specific for the elderly patient. And we can't be so discriminatory, but obviously high up is medical issues. They've got to be fit. And we then assess any patient, for that matter, whether or not they could tolerate a general anesthetic or a local. And whilst we do a lot of locals under for the elderly, we have done some pregnant ladies who wanted to be able to hear their baby cry, but because of pregnancy and the risks of anesthetics, we waited to the last trimester of life. That's another little story. It was mentioned earlier on in the meeting about life expectancy, and we need to know about concurrent health issues, especially cancers and other serious end-of-life diseases. Cognition, mental health, communication skills are paramount, and the ability to participate. A lot of our patients now perhaps are widowers or widows and they live by themselves, and it's then having the support, not only once they've had the implant, but being able to talk to somebody after it to be able to use their implant. So having the engagement of the family is vastly important. And the other thing is, who is driving the request? If we get a feeling that it's granny can't hear us anymore, they need an implant, but granny doesn't want the implant, we've got to find out from the family what their desires are. But occasionally you have an elderly adult who probably doesn't want to take the plunge, but with the support of the family will do so, and they can get excellent responses from it. And we've seen the quality of life, it can make a huge difference from isolation and improving cognition and things. Other area is expectations and motivation. And whilst we're in one unit and we cover quite a vast area, not like America or anything like that, but 100 miles traveling in the United Kingdom can be quite a long time. And if there's poor timekeeping to appointments and it's persistent and there's lack of motivation, raises the areas of concern. So when we analyze it, if there are probably 2 or more areas of great concern, then when we do the MDT process, it is a concern to us. So it may be that we give a negative to giving them an implant. Moving on, alluded to the principles of local anesthetic, and I think we underplay the role of anesthetic in otological surgery. And I don't want to go into details of how we do it because it's been written about in great detail, but 1 or 2 pearls of wisdom is the patient and the family we go through really every nut and bolt of the procedure, what happens every stage. You go into the preoperative room, you go into theatre, you have monitoring, and making sure that they're comfortable. Remember, if anybody's been on an operating table, it is very hard and uncomfortable. So we make sure that they are comfortable, putting pillows, making sure that they're going to be there for an hour or so. And one thing we found that's very useful is, you see in the picture, what we call cue cards. We've developed a battery of these things, and we have a big table, and they're put in a sort of order. But the important thing is to make sure that they can read them beforehand. If they wear glasses, can they wear them or at a font that we print out that they can see them at a comfortable distance without glasses? We've had adapted glasses by taking one of the arms off so that the glasses can be taped to their nose so they can actually read. That's a bit unusual, but something to consider. People have suggested sedation. Again, we've not done that because we want a cooperative patient. If somebody starts under sedation, moving around, and you can't communicate with them properly, you've got a problem. And people have, I gather, abandoned the surgery. Now, the other one is we're all well aware of the caloric effect, and we learned the hard way that we got some beautiful nystagmus in patients because we did the normal room temperature irrigation for the drill systems, and they got horrible nystagmus and felt quite wretched. So warm irrigation, and also minimal suction if you're going to suck and get out, so that you're not continuously moving air into the cavity. So some interesting ways forward there. We go on to the issue of skin, and in one sense I was pleased that it's been picked up, and I thought, well, we're not the only ones here. Many years ago we did a study and looked at skin thickness over time, because magnets are attracting to the implanted magnet, and that is giving a squashability to the skin. Also, we found in the earlier days especially, is the distance between the coil and the internal package could affect transmission. And again, we studied this, and this is one of the earlier slides of the elderly, or the adults, I should say, showing the pre-operative skin thickness, and we measured that with a needle, and then we developed an electronic system to look at the skin thickness over time, calibrating it with the magnets within the implant, and also using a magnet strength attractor. So I had two methods there, which we validated. So it just shows that you're losing sort of 60%, well, 30% of your skin thickness. And in an elderly adult, you can be starting off with 4 to 5 millimeters thickness. So it's very, very important to keep an eye on magnetic strength and reducing it appropriately. So I'll give you some of our little horror stories. I don't know if my mouse is working.
Yes, it is.
Yeah. So the bottom right here is a lady. These are all relatively recent, and whether or not it's because of COVID and lack of communication, but here's the top of an ear, and this is the impression from a very tight arm from a glass. So that she had very heavy, I call pebble glasses, and the weight and the pressure there, and you saw the scabbing and erosion, and just underneath there is an electrode. So we've got to look at where the package is positioned and look at the pressure and indentation on the skin with glasses, and that can be a preoperative assessment. So if you've got skin marking beforehand, then what we can do is wrap tape around the arm in this area, or get the optician to make weaker glasses, or to take the spring out of the arms from closing. At the top right, I mean, hopefully we won't see many more of these. This is related to the magnet of the coil being screwed too far in. So the implant was just the coil was just literally resting on the magnet. But now I think most manufacturers have a completely flat bed, and you can't over protrude the magnet. A telltale sign here is an elderly person where you get skin thinning, but you start to get hair loss, and that is a worrying factor. And this gentleman was on the weakest magnet that possible. So we then started to put packing little moleskins in to really reduce that pressure, and we're watching it like a hawk to make sure that it doesn't break down. And
Hey, Chris, can you finish?
Yeah, and this is a lady whereby the electrode eroded, and over about 4 or 5 years we just monitored, and eventually it decreased. So I will leave it at that. Thank you.
Thank you very much, Chris. Can I ask you a question? What percentage, more or less, approximately, you do on the local?
Oh, I don't know what the percentage is, but we've done about 40 or 50 patients over the last 3 or 4 years, which I don't know, maybe say 5% is a rough guess.
Okay.
Once every couple of months we'll be doing a lady. So anybody over the age of 80, we basically offer a local anesthetic, or because of medical reasons, we just say, we'll do it under local.
Domenico, you have the same percentage? You also have patients under local when they are over 80?
Absolutely no. I performed sometime. I remember 3 cases in 20 years, about 3 cases because of great problem with anesthesiologist. But anesthesiologist told me that it's more distressing for the cardiovascular apparatus, just the local anesthesia rather than the general anesthesia.
Professor Hagen,
This was
have a
also
different opinion?
This was also my concern. Is local anesthesia really less stress for the patient than general? I do not think so. And another thing is I failed 2 weeks ago in an older patient who refused general anesthesia because he had the wrong personality. And I didn't see the patient before surgery. Otherwise, I would recognize this problem. So you also have to look, is the patient really suitable for local, for lying for 1 hour? He's deaf and you have no communication. So this can be problematic in some patients. But my question was the expectations. You mentioned the expectations, and there are different expectations, but all the expectations of the patients depend on a correct counseling. Counseling is, and of course you cannot have the same expectations in a young child or just a young adult than an old adult. Do you deal with this problem of expectations in your counseling process?
Chris, what about the debate about the local anesthesia and then the counseling process?
Well, we've not had a great issue. Our issue had been really driven by the anesthetic colleagues saying that, you know, we can actually do more harm. If you're implanting a 93-year-old, they say, look, do you realize they can die under the anesthetic? You're doing a benign operation. Well, it depends on what you divide by benign, but you are trying to improve quality of life. It's not as if you've got a burst appendix or a broken limb that you have to fix. But they really brought it down to us that people, the wind can be, we call it wind, be taking out their sails a bit, and it does take them a few days to get better. And obviously during COVID, there was great reluctance to give general anesthetic to patients because of the risks in rehabilitation. So again, that was a driving factor. But I would agree with Rudolf, you've got to see the patient, and patient selection is everything. And you get a sense very quickly whether or not the patient will be accepted or not.
And what about the lack of rehabilitation that was mentioned during the last Mentimeter question? Daisy, do these patients have a risk of lack of rehabilitation more than child or younger adults?
I think so, Javier. I think so. There are 2 factors very important here. One, it was mentioned before by all the members, is the fact that they may not have enough support, not enough support, maybe it's not the word that I'm looking for, but enough social interaction. So they have much less opportunity for what we call passive rehab, right? So in our center, we try to provide rehab to the elderly the same way that we do for kids, like really actually bringing them to clinics, particularly those who know that they live alone or they have very limited social life. Yeah, so it is very different. Another thing is technology can be very challenging for these patients. So trying to make it very simple for them, even for the rehab point of view, like in using audio input. So we actually really try to personalize it for the age, because they can have a lot of issues assessing the rehab material that we use. One thing that I just want to bring to the thing, for example, for our group was a huge learning curve, and I'm sure that was for everybody else as well. During the COVID, the elderly patients, they were the ones that suffered the most. They could not come to the hospital. They did not want to go to the hospital, right? So I think that we learned a lot how to adapt to the technology to make it much simple to communicate with them using the telehealth or video conferences, this type of thing, what can be a quite challenge for them.
Good. Let's finish our journey by moving from Bradford to Antwerp in Belgium. And we moved to Antwerp to meet Professor Griet Mertens. Griet is professor at the Antwerp University, and she's coordinating the clinical cochlear implant research program at the ENT department of the Antwerp University Hospital in Belgium. She's the co-author of more than 40 papers in various national and international journals and has presented her research outcomes at more than 50 international conferences. We are delighted to have Griet among the distinguished members of our group. And now Griet Mertens is going to deal with the outcomes of the hearing R-bands age study. Griet, it's everything yours.
Thank you, Javier, for the introduction and for the invitation to share our results on our R-bands age multi-center study. So I'll start sharing my presentation. There we go. So by way of an introduction, and like Javier already told us, first of all, I would like to convince you why this topic is important. It's a well-known fact that our world population is growing dramatically during the last few decades. And thanks to the improvements of the health and living standards during the last years, the world population is not only growing, but aging as well. And along with this aging world population, the prevalence of dementia has been rising as well. So in 2015, about 47 million people worldwide were suffering from dementia. And if no cure or disease-modifying therapy is found, then it's expected that this number will triple by 2050. Now, it's a well-known fact that if we grow older, our cognition deteriorates over time. That's a natural process that we cannot escape from, unfortunately. Moreover, there's also evidence that this cognitive decline is going even faster in patients with a hearing loss. For example, the study of Lynn and her colleagues, they reported that hearing impaired patients have 20%, 24% more chance to develop dementia over time. Now then, of course, the question arose whether we can stop the accelerated cognitive decline in hearing impaired older adults if we restore the hearing, for example, by making use of the hearing loss. And indeed, hearing aids were found to have a positive effect on the cognition in hearing impaired older adults. Following that, our research group was interested whether a cochlear implant can have the same positive effect on the cognitive decline in older adults with profound sensorineural hearing loss. And therefore, we started with a systematic review aiming to give an overview of the existing literature about cognitive outcomes after CI in older adults. The conclusion of this review was that indeed the reviewed studies performed pioneering work. They were indispensable for the field. However, up until then, they provide not conclusive evidence of improved cognitive outcomes after CI in other adults. So therefore, we decided to set up a prospective longitudinal study in which we tested the cognition prior to cochlear implantation and also 12 months after cochlear implantation in comparison to a control group, patients with the same degree of hearing loss, but without the intervention of getting a cochlear implant. And we did this study together with the colleagues from the hearing group. So also a special thanks to these colleagues for the nice collaboration. Now, the problem of testing cognition in severely hearing impaired patients is, of course, that prior to cochlear implantation, the instructions of a cognitive test, they cannot be heard very well, or just not, or very limited. So therefore, we went looking for an appropriate cognitive test battery in order to test our hearing impaired older adults. And we decided to adjust the Arbenz test tool, which was originally developed for patients with a normal hearing. And we've added a PowerPoint presentation, so with written instructions and additional visual support, and that's how the Arbenz H was born. This Arbenz H consists of 5 subdomains, so we are able to test immediate memory, visuospatial, language, attention, and so on, just by making use of the Arbenz H test protocol. And here on the graphs, you see the improvement in cognition on the vertical axis. So 0 means no difference between the pre and the post-op score. And as you can see, also improvements in the control group were observed. Now, the main advantage of our study was the inclusion of a matched control group, so patients with the same degree of hearing loss, but without the intervention of cochlear implantation. So after correcting for this improved cognition in the control group as well, the improvement of the total Arbenz H score remained significant in our interventional group. And in addition, also in comparison to our control group, a significant improvement in the attention subscale was found as well. The secondary outcome measures of our study showed an improvement in level of anxiety and depression, an improvement in sound quality and quality of life, also reduction of the reported hearing handicap, and of course an improvement in speech perception was observed after cochlear implantation. However, another important improvement after cochlear implantation in our older adults that gains a lot of interest during the last few years is the cognition of our older CI recipients. I only had 5 minutes for this presentation, but if you want to read more about these data, I'm happy to refer to our recently published multi-center study paper, which has been published in Ear and Hearing last year. Thank you very much for your attention.
Well, thank you very much, Grid. It was concise and very clear. Now, the question is, these patients improve with a CI, but improvement means that they reach the same level as their younger peers?
Unfortunately not. So indeed, there's a very positive effect of the cochlear implants on their cognition, but we also did a cross-sectional study to compare patients with the cochlear implants in comparison to their normal hearing peers, and there they still perform worse than what's normal for their age. So the normal hearing people, they were achieving an Arbenz score of 100. It's a little bit similar to an IQ test. So 100 is normal for the age, but still our CI, our experienced older CI recipients, they are performing worse on the Arbenz H score, lower than the 100 score that's normal for their age.
And I understand from the study we did, there were 2 populations, one with CI and the other without CI. So try to convince me not to use a CI.
Yeah, it's indeed not ethical correct to randomize them into a group achieving a CI or not. So that's why we were very lucky that we have the colleagues from all over the world, because we've got the different reimbursement criteria. For example, in Warsaw, they have access to a CI earlier with a lower degree, with a better hearing. So a patient with, for example, a pure tone average of 70 dBHL would end up in the intervention group in Warsaw, but unfortunately in Belgium it's not reimbursed, and they would end up in our waiting list in Belgium in the control group. So then we've got a nice match because we are working multi-centric. It's a nice advantage.
Good. Let me go back to and we bring the discussion to all of you. Let me go back to some issues mentioned before. We were dealing with the problem of lack of rehabilitation again, and the idea that older adults are not able to reach the attention, the care of their families. Maybe they don't have a family and they are going to a nursery place. So how does this impact the indications? I mean, Chris, I think you mentioned that some patients may not be able for a CI depending on these conditions. So you will not put a cochlear implant to a patient that doesn't have an engagement, a social support enough to take care of him or her during the post-op?
If that can't be addressed and corrected, I mean, I'm stressing on the factors of fixed things like the radiology and audiology, you can't change. But if you can manipulate the care home or the carers to sort it out, that would be one factor. But we said if you have two great concerns, then that would be a concern to implant. But I think you might get better motivation if you highlight the problem. And in most situations when we've done that, we get support from the family or the care home once they realize.
And is the same, you have the same problem in Italy, Domenico? You have patients, older patients that do not have support and have a very serious hearing loss and need a cochlear implant, but they are going to receive the cochlear implant or not? It depends on the support, the family, the state, the institution, or how does it go?
Of course, depend on the motivation and a minimum set of support, that especially for the older, because people living alone, don't moving from their home with really with minimum support. I think that is a great problem to manage properly similar cases. But anyway, the motivation may make sense also in these patients.
So the problem is that
is made on an individual base.
Of course, but I understand the situation. So this patient that has not a good support from the society or the family, if he or she doesn't get the cochlear implant, his situation will be worse. So I mean, maybe I'm going into a vicious circle and this has no solution. But you have any solution for that, Daisy?
Javier, I don't think that anybody would say that is an exclusion criteria, right? If you don't have a family or social support, you are not going to implant this patient. But it's the fact that you have to address that and you have to be very aware how you are going to work with these patients. Because I agree with you, if we don't provide them the hearing, then that's it. What is the purpose, right? Because many of them, for example, they have living in the nursing home, they don't really have a lot of support, but they don't join, for example, the group for cards, games, anything like this, because they don't hear. If you get them a little bit of hearing, they actually do that. So it's a huge improvement in quality of life. Maybe your speech score is not improving significantly as we would like, but their quality of life is their confidence and their willing to go to that card game. If that's what you are going to get, that's what you are going to get.
That's the idea I had, yeah. So another question, I mean, we all do screening test for child, right? This is natural. But with the older adults, I mean, at least in our experience, we wait for the patient to come to us. And I think we should prepare something to have a screening test or something like that to find the patient, not having the patient coming to us, but going and finding the patient because of this screening test. Do you have something like that in Antwerp?
I totally agree that there's a difference between children and the older adults, and that's what we are struggling with as well. But I'm not able to provide already a solution for this problem. I think counseling all the stakeholders, so that means family, the patient himself, but also the HP, also the audiologist working in hearing centers to
And the NHS in the UK does have something like that?
Well, yes, we've obviously got newborn screening for the children, which works extremely well. What we have been doing, certainly in our own region, and it's going out through the British Cochlear Implant Group, is analysing the audio base, most of the audiograms are now computer-based systems. And if you put a program in to filter out certain hearing levels, it's also bringing it to the attention of the audiologists. Despite cochlear implants being around for 30, 40 years, the junior audiologists, a lot of them don't know what the criteria are for cochlear implantation. So it's education and re-education and education. From another angle, before COVID, we had meetings we called Bend the Spend with our colleagues in Westminster in the House of Parliament. And Adrian Davis was leading the forefront of trying to do a simple screen at 3 kilohertz from the age of 55 onwards, just a simple single tone, and to see whether or not people just needed hearing aids, let alone cochlear implants, because you know, there's a sad lack of use of acoustic aids.
Yeah, I understand that, and I totally agree. Professor Hagen,
We had a
question.
very good idea with the screening for elder people. Maybe the only chance is to go in contact with the general practitioners, because these general practitioners see all the patients with other problems, but really seldom they say, okay, maybe he has some hearing problem. And if we push this regard in the field of general practitioners, maybe we can then bring this problem a little further. That's my opinion.
I agree with you, Domenico. Do you have something like that? I mean, is it possible in Italy to have the GPs going and providing information and awareness to the patients, the elderly patients, and bringing them to your office?
It's a very complicated problem. This, in the past, we attempted with our society to give some make sense campaign on this problem, but we have to overcome also another aspect, because all people, at least in our country, but I suppose is the same everywhere, are submerged of ads from hearing aid dispenser. So they don't like a lot this campaign, because they misunderstand the message. If the problem is that give a screening for cochlear implant, we are speaking about this in another discussion group. I think that a simple screening is to consider a rule 60-60, more than 60 dB, less than 60% in speech perception. But this is a message for hearing aid workers, for hearing aid dispenser, for hearing aid audiologists.
Okay, we are at the end of our roundtable after an hour and a half almost. We have been dealing with cochlear implants in elderly patients, and I would like to wrap up and summarize the presentations made by our experts today. The first idea that I consider very important is that there is no age limit for cochlear implantation, and age is not a good predictor of cochlear implant outcomes. And if you learn this, you have learned a lot from this roundtable. And I would like to also emphasize that you know right now that the lack of communication in the elderly can be even more destructive than for the rest of the adult population. Cognitive decline goes hand by hand with hearing loss in the elderly patient. And in these situations, CI may be a life jacket helping the patient to connect to the world and delay the cognitive decline. According to the National Institute of Aging, hearing health is essential in our aging society, and cochlear implantation helps to keep older adults with severe to profound hearing loss active and well integrated in the society. From a purely technical standpoint, there are also differences. You've been aware of that. When dealing with elderly patients, skin issues constitute a major concern, but probably the most important technical differences refer to anesthesia. And you saw a debate between local anesthesia or general anesthesia. You have to solve that according to your own practice, because the main problem for these patients is not only age, but also the comorbidities usually present in this group of the population. Maybe this is not the solution, the local anesthesia for all patients, but in some situations, it should be considered as an option. Discuss this with your anesthesia team and get to an agreement. Surgical recovery may also be different and longer than in younger patients. But this is not all. Rehabilitation in older adults also has some peculiarities that should be taken into account when you face a cochlear implant for an elderly patient. And finally, as we were discussing right now, we have to increase awareness in this group of patients, because right now they come to us, and in the future we should find them as we do with children. After almost the hour and a half gone, I just want to thank you all for your participation. And before closing, because we are almost out of time, let me mention some practical issues. You can visit our webpage at www.hearing.com, and here you can find different tools. You have the hearing preservation calculator. This is a very good tool. It's an Excel sheet where you can calculate the hearing preservation in electroacoustic stimulation, in hearing preservation techniques. You have the electroacoustical stimulation fitting tool, also another tool that is very useful. And you have the counseling platform right now, useful for EAS and for bone conduction devices, but it's still under construction. So you can find a lot of help in this web page from the hearing group, where you can find the two basic pillars of the hearing group, which are the quality standards in the web page and the Hearing Boost. The Hearing Boost is our educational platform, which is basically a learning management system that are available, both of them, at the Hearing web page, as well as our accreditation for the courses, including this roundtable, because this roundtable has CPD accreditation. You can request the accreditation by sending an email to boost@hearing.com, and after a while, it may take up to 6 weeks, you will get 1.5 points for this hour and a half of roundtable. Well, this is the last comment I will do. Please send us any doubt, any comment, any question you have to www.hearing.com, and we as a group will be more than pleased to contact you and answer and debate with you any issue you want to deal with us. This has been our last roundtable of the year. The program for 2023 is still not finished, but you will have information as soon as we have it ready, since our intention is to continue with this activity. We hope to see you here next time. Thank you to the panelists. Thank you all for being there. And until we meet in the next roundtable, please keep safe. Contact us if you need something, and have a wonderful Christmas season and a happy New Year. Goodbye.